Thanks, Devi. What an amazing session and some really cool technologies. Welcome back to day 2 of the plenary session 4 of Rhythm Interventions Online 2024. My name is Richard Schilling. I'm from London at St Bartholomew's Hospital and Welbeck Heart Health in London. This session, and indeed the next few sessions, are actually going to be focusing on electrophysiology. This session is looking at advancing complex AF cases and case workflows with automated indexing and near-field mapping. I'm really excited because we've got a world leader giving us a great live case, Isabel Deisenhofer and her team from Germany Heart Center in Munich. And we've got some really good panelists. I'd like to introduce Finn Akerstrom from Stockholm in Sweden and John Silberbauer, one of my colleagues from Brighton in UK. Welcome, gentlemen.
Good evening, Max. Richard.
So let's join Isabel and her team at the German Heart Center in Munich. Isabel, over to you.
Yeah, it's a pleasure to be able to participate in this great congress. Thank you for having us. And as you can see, we're here in the largest of our 3 labs, which gives us the opportunity to really show you nicely what we're doing. It's my pleasure to have with me my team members. So there's Nico Erhardt here to my left, who will assist me during the case. Then behind me, there's Dr. Tunsch, who is introducing a little bit the patient afterwards and assisting on the BART machine. And then our 2 nurses, Ursula and Annie, who will help us keep the patients sedated. And Alex Duda from Abbott, who will master the machine, the NSIDX, which we are going to use today. We are going to use, in fact, for the first time in the EMEA region, the HD Grid X. So the HD Grid's mapping catheter with additional sensors. And we're all very excited because as you can imagine, it's one of the first we're trying. So you're assisting a little bit in our premiere. Exactly. So what we're doing is that Nico is briefly introducing the case to you. Exactly. Okay.
Okay. Hello, everybody. It's my pleasure to quickly introduce the patient to you. So what we have here is a 82-year-old woman who actually first presented herself to our center in 2022. She had a mildly reduced ejection fraction and had highly symptomatic AFib, which reoccurred quite often, and previous cardioversions had failed. So what we did is a first-time ablation in 2022, where we did a routine CT scan, which we really like to do here because it gives us a lot of information about the anatomy, in addition, obviously, to exclude possible thrombus formation. So this is what we did back then, just to get an idea of the atrium we're dealing with. And if we can have the next slide. So what we saw was a posterior, quite actually an okay voltage. And if we look at the anterior wall, we already saw quite a huge scar on the lady. So we already knew that that scar might also be something in addition, maybe to the PVs, which is going to cause some trouble during the ablation. However, actually the first AFib ablation, which we did, went quite well. And what we did is obviously a wide circumferential PVI doing a high power short duration protocol. And in addition to this, we did some substrate modification anteriorly due to her large scar. And actually after that, it turned out that the patient went quite well for 2 years. Unfortunately, now reappearing with atrial tachycardia. And now we actually have this documented within our Holter ECGs, and we have this attack documented, and she underwent 1 cardioversion, but despite that, she has that flutter now, and that's the reason she's here today. And which leads us to our question to the audience is, what would your approach be in this kind of scenario? Are you an old school guy and do you rely on entrainment only? Are you very new school and do you want only the LAT? That's all you need. Do you entrain first? Do you use the LAT first, or the other way around? So please give us your answers next to the video now to get some feedback and some engagement going. And now we're going to go back to Isabel who's going to show you what we already did.
Yeah, thank you, Nico. And was a case where we thought, okay, that might be nice to show. We, of course, placed the CS catheter first, and here in the heart center, the CS for you just is always arranged on the screen in a distal to proximal manner. So up is distal CS, and then down there comes the proximal. And you can appreciate it's this proximal to distal sequence with almost 300 milliseconds cycle length. What we then prepared, and I hope you can see it then on your videos, is that we sort of did the transeptal puncture, and we do it here pressure controlled. Exactly. So you might appreciate here that we crossed and we had a very high LA pressure. So quite a damaged atrium. But what you could see in the previous NAVIX maps is that this is one of these tiny old ladies with a quite fibrotic left atrium, but not very large atrium. So a small damaged left atrium. Very interesting. And we did not start yet mapping, so we wanted you to participate in that. And that's what we are going to start right now. So could we have the other screen arrangement, please, where we can see the NAVIX screen? And I would need a chair, please. Are there any questions until now? We just rushed through this.
I think it would be good to know and just to explain the nuances of the HD Grid X and why that might make a difference to the mapping process here.
Yeah, I mean, I think that those who know mapping with the HD Grid know that the sensor is on the shaft and then not very distally on the shaft. So when you have the HD Grid, obviously in a long sheath, you always have to take care that the sensor is quite far out of that sheath. And that, of course, then leads to a problem that the distal end of the HD Grid in the beginning, when there are not so many voxel points yet acquired, is sometimes doing what we call a hello waving, because the system is not very sure where the distal grid is. And then the grid starts to sort of wave like a hello waving. And what you can appreciate now, that's why I, on purpose, did not start the mapping, is with these new sensors, which are placed on the tip of the grid. And maybe you can see it. No, it's not really visible in the fluoroscopy. The system recognizes immediately where the grid is. We don't have that hello waving. And it's immediately collecting with high confidence positioning voxel points. And that's, of course, something that shortens that mapping process a lot. I have to be honest, we normally with a normal HD Grid, we very often do a first exploration of the left atrium with the Tactiflex, with the ablation catheter, to have more voxels already collected and to have better anatomy than with the HD Grid. But that's not necessary anymore. And that's, of course, a very nice feature. And it goes along with what we are used to see in the HD Grid. Very, very nice signals, high density mapping, and so on. So I don't know how you do it. I always start on the left veins. And as you can appreciate, there seems to be a durable PVI after this first ablation. Maybe something here in the carina in between the left veins, but not a lot left. And then
I think
normally
many of the mapping catheters that people use, the electrodes are parallel or adjacent to the shaft, like the lasso or the pentaray. Whereas, of course, the HT grid's got
Yeah.
unique morphology that the electrodes are sticking out quite distally. While you're doing the map, maybe I can ask John, because John, you do
Yeah.
quite a lot of epicardial AF mapping, and presumably the reflections on the roof mean that you can't get the shaft up there necessarily. And do you have problems with the conventional HT grid creating voxels in that region, or does it get solved by doing endocardial geometry first?
We do the endocardial geometry first, because actually it's quite difficult to understand the epicardial atrial geometry without the endocardial left atrial geometry, if that makes sense, because you just have the oblique and transverse sinus. Having said that, I mean, I'm fascinated to watch what Isabel's doing here, because normally you have to go deep inside the pulmonary veins to get the magnetic sensor right deep into the pulmonary veins before you can actually start acquiring. You go backwards and forwards, and it's really a delayed start to the procedure. So I think we can already be quite confident, just with what we've seen so far, that this catheter is mapping much faster. So there's some minutes have been shaved off, I would say, already.
Yeah.
Question about
I can tell you, it's my. I had to admit, that's my first case, because I missed our other first case yesterday. So I'm quite fascinated myself, because it makes really a huge difference.
But it's good to see that there's clearly no learning
point,
curve.
Richard. It's we are actually able to get it deep enough, even in the epicardium with the sensor. So that's not an issue. It's really it's a time saving thing rather than a feasibility factor, I would say. The other thing that I'm really interested in is, carry on.
Sorry, I was going to just ask Finn. So I normally start in the left atrium, but I always want to check that the veins are isolated. So my view is I'm going to check the left atrium anyway, but we can see that the coronary sinus is proximal to distal. Would you do something different and look at the right atrium first, or would you also go to the left atrium as your starting point?
That's a very good question. I think the issue here is the left atrium. We saw that in the initial map from the previous ablation. And just as a comment, I'd be very interested to actually see the lesion set, how much ablation was done on the anterior wall. I guess there was no mitral line that was done at the point, but that would have been just to look at that, because you would worried about, creating substrates for perimitral.
Yeah, you're right. Yeah, we did not complete it to a line. It was more an electrogram-based approach, but we didn't show it. You're right. So I missed the point. Yeah. No, there were a few points on the base of the left atrial appendage. Not a lot, to be honest, and just placed in sort of some spots where we found that the electrograms were really fractionated. So it was an electrogram-based approach without an intention to draw a line.
But just to come back to answer the question, I think in this case, I would have done transeptal punction, and I would have done an entrainment just to start off with from the distal coronary sinus, where you can get nice, in this case, probably downstream entrainment, and you could also confirm the whole involvement with the mitral annulus. That would have been nice, because I think in this particular patient, it would be really easy to restart the tachycardia. It seems like she's getting a lot of the of this tachycardia. Which, but then I would want to make a confession.
I have to make a confession. We did that, to be honest.
Yeah, I think I saw that earlier on.
Yeah. And the both distal and proximal CS were entrainable. So we're quite confident that it's a perimitral flutter. And to be honest, I always do it. I try to do entrainment always first, even if I know that I'd like to, of course, check the veins and go left anyway. So we wouldn't stay in the right atrium just because it's only a typical flutter. We would have checked the veins anyway, but just to know during the case what is the consequence and so on. So with a 300 milliseconds flutter, I don't think that you will destroy the flutter with the entrainment. We didn't. And so we checked for it, and as I said, both. It's maybe visible on the BART screen. If you look at the analysis BART screen, that was the entrainment with a proximal CS, and maybe we can have the other one.
Yeah. When you train from the distal CS, you actually had orthodromic capture of the proximal CS, which
and then
confirms the circuit
exactly,
by
and
just one entrainment.
that you see here now. Yeah, that's then entrainment from the distal CS, and you see that orthodromic, as you say, no change in sequence, and it's really a concealed entrainment, and then you're of course very sure that it almost has to be paramitral.
So I never entrain, and it shows.
Really?
I would be wrong here because the map looks as though it's right atrial flutter as it's shaping up at the moment. So maybe I'm out of step. John, do you entrain all of your atrial tachycardias or most of them?
We never entrain. We always do the activation map first. We just don't want to risk stopping the tachy, basically. And I think with modern mapping systems, it's quite rare that you can't understand the mechanism via the activation map. That's our practice in Brighton.
So it's a 50-50 split. So whatever you do at home, it's fine because half of the group entrain and half don't.
Yeah, that's funny. No, I'm a fan of entrainment, to be honest. Here in my group, I have, I think, a very bad reputation for entering labs and asking always if the entrainment was done. And then they look at me like, yeah, but we did an LAT where I say, yes, but still. So I don't know. I'm old-fashioned, probably. Can I see PA, please, in the left?
The other thing I find difficult to do is Isabel, is to trust the computer's timing of things. And I suppose it's just a reflection that I'm incredibly old-fashioned, and I use the ablation catheter to go around point by point just to check the timings, because it looks still very much like this is right atrial flutter to me on the on the activation map, but the entrainment tells us otherwise.
Yeah, maybe we did a mistake while we entrained. I mean, we can. I never only trust LAT maps. I always do an confirmation entrainment, and that would be as you maybe do it with the ablation catheter. And for this purpose, just to differentiate as fast as possible perimitral from typical, I would go to the left mitral isthmus and then entrain with the ablation catheter and have a look. And if that's positive, I mean, then typical flutter is out, and then it almost has to be.
But if I just make a point, I think this patient is very likely to be having a CTI flutter, a perimitral flutter, and a roof flutter. It's got substrate probably for all of them. So they can be changing interchangeably, and even with the entrainment to another one. So she probably needs ablation for all three, I think.
Yeah, I mean, looking at the previous map, maybe we can see once already a little bit of the voltage map, just to give us an idea, because she had some scarring on the roof already before. As I said, the posterior wall was quite good. And the anterior wall really had low voltage. I have to complete the anterior wall, but still. So as I said,
You raise a really interesting point here, Finn, because empirical lines, I mean, the mitral line always makes my heart sink, because I think it's much more difficult to achieve than we give it credit for. And so I'll try and avoid it unless there's really good evidence. What's your experience of getting block on a mitral line, and what are your tricks?
Yeah, thank you for the question. We've been doing the ethanol ablation of the vena marshal for I think 2 years or something like that, and since we swapped to that, it's been much easier, much easier to have acute and also chronic block of that line. I think our experience with anterior lines is mixed, and some of them are coming back, and in some cases we've done epicardial ablation of the backmass bundle in those cases. But I think in a patient like this, now I haven't seen the voltage map fully, but if she's got a large anterior scar, I think it's probably a patient where you probably need to do 3 empirical lines to prevent future atrial wood, to prevent the 3 most common macro-reentrant tachycardia.
And with scar like this,
Yeah.
would you do it with ligament of Marshall, or would you just extend that scar onto the right upper?
That's a very good question, because you would worry about if you do, posterior line with ethanol ablation of the vena Marshall. You could, if you have a larger anterior scar, you could isolate the left atrial appendage. So that would be my worry. So I would really carefully look at how big is this scar, and if it's big, I'll probably do an anterior line, and perhaps be prepared to do epicardial ablation of the backmost bundle, which John has got much more experience with. That's what I would do. Yeah.
John, what's your thoughts on mitral lines and how you manage this?
I think it depends if the patient has scar or not, really, on the anterior wall. I think if the patient has scar on the anterior wall, there's a reasonable chance of blocking it endocardially. Whereas if there's very little scar, it's probably a bad idea to take on an endocardial anterior mitral line. We have found with the addition of epicardial ablation that you can reliably block over 90% of these, and it's pretty much always due to the Bachmann's bundle, as Finn just said. So just septal to the left atrial appendage is normally where you would get it epicardially. I think if you weren't happy to do that, then probably ethanol with a vein of Marshall makes more sense. It's also a reliable technique for blocking the mitral line, and we do that in cases where we can't get epicardial access. For example, patients with prior pericarditis or surgery. But in this case, we would definitely be taking on, as a minimum lesion set, I would say, CTI roof and anterior mitral, possibly the floor line as well.
Great. So Isabel, what's your thinking now? Your map's almost complete there. What's your thinking?
Yeah. I think, as I said, I agree that looking at the colors, it looks more like a right atrial flutter. And I'm a little bit irritated by that. So we will have now just an analysis of the arrows, which I like a lot in the NAVEX system. But here, looking at the propagation, it doesn't look like perimitral, to be honest.
Isabel, can I ask a question?
So we were just discussing,
I was just wondering, did you do the entrainment from the proximal CS second or first?
First.
First, okay. I was wondering whether the entrainment may have changed the tachycardia.
Yeah, I was thinking of that.
But
Looking back at that entrainment of the CS1-2, so with the distal entrainment, we were just discussing, was it captured correctly? And did the sequence in the CS change in the meantime? But it doesn't look to me. And you know what? We're just looking at the LAT map, which looks like a typical, with a breakthrough from the right to left. And we're redoing the entrainment with the ablation catheter, as I said, in the mitral isthmus. It could be, of course, and that's I don't know who of you already alluded to that. It could just be that this is sort of a double re-entry with a leading loop and a less leading loop, and that she, in fact, is able of both typical and perimitral. But we'll have to look at the entrainment. So now my ablation catheter would be placed in the left lateral isthmus, and we're just doing entrainment. It's, I think, now 290 approximately the cycle length. So let's try 270. And it's not.
Okay.
It's not captured. Can you do it again? Now it's captured. And it's not so long, huh? Can you measure it? Yeah. So now it's long. We have 370. And I think the problem with the proximal CS pacing was that it wasn't captured correctly, properly. And we got fooled. And it's typical. So let's have a look at the Navix map. Can we have the arrows on the posterior wall? Yeah. And then maybe we can follow these arrows. And I love these arrows, to be honest, on the HD grid, so that you can appreciate that it's really one breakthrough from right to left on the posterior wall and concomitantly on the anterior wall. And the whole left atrium is more or less activated from the septum to the lateral side, and appendage is the latest. So whatever it was before, or we did not really capture in CS1-2, or it was then a different re-entry. Okay.
It would be interesting to look at the entrainment that you did initially and just measure that you actually accelerated the tachycardia.
Yeah, maybe we can go back to that CS1-2 entrainment. Yeah, and then maybe go to the atypical. Yeah, and can you? Because for me, it looks as if it is captured. You see the reaction of the CS. I think it's captured, and it's, from my view, it's entrained. So at that point in time,
the tachycardia cycle length after the entrainment, so it hasn't.
Yeah, can you do that, Alex? Yeah.
Just two A's. Yeah, that's very interesting.
Yeah, 290 was it before. And yeah, I think it's capturing and it's in trend. So it changed, or we changed it maybe also during
I think you're
mapping or entrainment.
I think you're just fulfilling your mission, Isabel, to show us how important near-field mapping is. Much more important than entrainment. Can you tell us a bit about near-field mapping?
But I, when I look at that entrainment, then I have to say a perimitral flutter is at least possible in that patient. I mean, it's sort of suggested by that anterior scar. And of course, as you pointed out before, a flutter around the right pulmonary veins over the roof is also an option. Not in our propagation map, I think. No, can we see simultaneously AP and PA with the arrows and the propagation? Can you center it? I'd like to just to say no, because it's running up the posterior wall and coming up also the anterior wall. So I think that this propagation is not around the roof, but again, it would be something that would be possible. Can we have underlying, not the colors of the LAT, but the colors of the voltage map once? Yeah. And if you maybe tilt a little bit the left image to the roof so that we see a little bit, yeah. So you can see that there were these formal lesions for the pulmonary vein isolation, and it could be also here a slower conduction over the roof. So it's a third option. And as somebody of you said, we will end up with 3 lines, I feel, in this case.
Well, can you just tell us a bit about near field mapping? What is that? What does that mean?
Yeah, that means that you have in the HD grid the possibility to look at these signals, knowing where the next electrode is. So you have an omnipolar mapping. That means that you can look at these electrograms in a 360-degree manner. And on the same time, the system looks at the unipolar recordings and cleans them and puts them together with a bipolar. So in the end, you have an extremely high density, clean mapping of these electrograms, and you know the timing of the electrograms with the grid, so that you can really see in which direction the propagation of the wave is taking place.
So we've got a really interesting observation or a couple of interesting questions from the audience. Marcel Affair has pointed out that they think that the LAT map doesn't have the whole tachycardia cycle length. And if that's the case, can you explain to the trainees, Isabel, why that might be and what's going on there?
Yeah. Because now at least now, for me, that's typical flutter with a high probability at least. And then we are mapping the passive atrium. So the left atrium just gets activated passively from the right side. So you won't have the whole cycle length. And that's, in fact, one of very, very important observations while you look at these LAT maps is, do I have the whole cycle length? And if I don't in one atrium, then I have a problem because that's the wrong atrium. There is one exception to this rule. And we had that, in fact, during a live case for the ERA, that was that the whole cycle length was buried, or parts of the cycle length was buried in an extremely slow conduction area on the anterior wall. And if you look attentively on the right-hand image in the NAVEX, and maybe we can have the voltage again in that image, you see there is the low voltage, and you see that the arrows there go all over the place. It's not activated in a regular manner. You see that? So it looks as if here was a very slow conduction area where you cannot follow the conduction because it's so slow, it doesn't even produce a proper signal. And then, although you don't have the full cycle length on your left atrial map, it can still be a left atrial tachycardia. And looking at that region here now with that low voltage, I'm just curious to do an entrainment there, because I still believe that this is, I don't know if this is typical flutter. I don't know. I'm still hanging on that idea that this has to be something left atrial. So you have to forgive me. Can I see AP in the left image, please?
That's perfect, because one of the audience has said there seems to be an anterior line of block, and of course, you can only tell that when you entrain either side of that line, because if it's flutter, it's not testing that line enough.
Exactly, and it's. Can we take away the pacing just for 1 second? If you look at the ablation catheter signal, I'm not sure if you can see it. It's barely visible. And I learned over the years that when you have a barely visible signal, but you're capturing here, you might not be able to measure the post-pacing interval, but if you're capturing here, you're in the middle of the slow conduction area of that reentry. So you can take that entrainment, just testing the capture as a test if this is part of the reentry. So let's maybe try here.
While you're doing that, let me ask John, because I often see discontinuity in tachycardia.
It's in training. It's capture.
Appearing to jump across scar. And your experience is that the atrium is a truly three-dimensional structure. There could be stuff going on epicardially that you don't see endocardially.
Yeah, we did a nice case where there was this, exactly what Isabel was talking about, where you have the missing conduction in front of the right upper pulmonary vein. And some of it... We were still missing a quarter of the cycle length, 100 milliseconds out of 400. And all of that was in the transverse sinus, connecting the left atrium to the right atrium. So I think, when you do start doing more epicardial mapping, you might be surprised as to the fact that some of these flutters that are difficult to understand, you can understand them. We measured the distance from those two, from the epi to the endo, is 1.7 centimeters. So,
It's quite thick. So Isabel, what's the entrainment then? What's your conclusions about that?
Yeah, it's shown in the upper screen. It's not that bad. It captures in first place. And it's 320 for a cycle length of 290. So just out. But we have problems to delineate the post-pacing interval because the signal on the ablation catheter is so tiny that we have promised to measure it. And what I just said, we're just going to remap this area here. So this anterior scar with the HD grid. And here you can appreciate in the green in D3, D4, there is some sort of delay over one bipole. I'm not sure. This is, of course, on the anterior wall of the left atrium. Well, now you can see it in the green recordings from the D-spline. There's something going on. To be honest, for a very localized reentry, I would have expected to have more activation during the whole cycle length. But now if you take together the signals that you get from the yellow and the green spline of the HD grid, you almost cover the whole cycle length. So we are just doing, again, a refined mapping of that area here. And on the other hand, of course, this is anteroseptal wall of the left atrium. A typical right atrial flutter could be entrained here with a longer PPI. So it's not totally excluded that it's just a typical flutter. Okay. So what we can try right now is to use entrainment even further and to go back to this area with these very tiny split signals and just try if we can capture there. Okay, so could we try here with A34, please? What's the output? 12? 10, yeah, okay, yeah, go. Yeah, it's capturing. Okay. So what we can do right now, because if it's an anterior localized reentry and it changed, then it shouldn't be entrainable with CS910 anymore. So we do a last check for this one. Please entrain with CS910. Okay. And it's still entrainable, and I think the post-pacing is perfect. So I think somehow it changed to a typical flutter. Okay. Yeah, that's now a difficult question how to proceed, because I like always to finish my ablations in the left atrium and then go back to the right, and then as the last step do the CTI. But then you won't see the termination, of course, so I'm sorry for that. We can still, since you're here and we have time, we could do a quick right atrial map with the HD grid, just to have a look if the right atrial LAT fits to a CTI. So you tell me what you'd like to see and we do it.
So let's do the right atrial map, Isabel. But tell us about your left atrial strategy now. Now that you don't have any true evidence of a left ATAC, what's your plan for that side?
I'd like then to go in between the left veins. If you can see here, I think you can appreciate a little bit. There's some tiny small reconnection between the left veins. The right veins are good. Yeah. So I would just do a re-isolation of the left veins and then go for the CTI and then try to re-induce. And if we still can re-induce, then probably end up with the other lines. But we just do a right atrial map in the beginning. No. Okay, can we record the withdrawal to the right side?
And Finn, you'd take a different approach. Would you be doing empiric lines in the left atrium anyway?
I think I was thinking about it right now, and I think these patients are quite individual. So I think I don't have like an overall strategy that is like one size fits all for these patients. I think in this particular case, or in general, if I have a CTI flutter, I like to do a CTI line first. And in the same way, if the pulmonary veins are reconnected, I like to re-isolate them before then I start studying more complex flutters that are from the left atrium. But then sometimes you end up in a scenario where the flutters are just, jumping from one to another, and it's impossible to map them or entrain them. And then that's when I switch to the empirical line strategy. The empirical line strategy I usually do for patients who are not inducible, well, mainly patients who have persistent AFib. Then we do the Marshall plan with these 3 line sets. So, but to individualize is my message, really.
Yeah.
Yeah, and I have to confess, I think that in this patient, we would do anyway an anterior line because it looks so destroyed and so like an invitation for the next flutter, this low voltage, slow conducting part there in the anterior part of the right atrium, left atrium. But now, we can do the CTI, and then we get rid of this possibility that it's still typical flutter, and then we can map whatever is there still.
And Isabel, would you connect that anterior mitral line to the right upper, or would you create a roof line and connect the anterior mitral to the roof line?
Well, traditionally, we connected it to the left superior vein and to the encircling lesion around the left veins. That was our traditional Munich line. We changed now and do probably 80% to the right superior, and I make it dependent almost uniquely from the voltage map I see and the voltage we have to cross. Because anterior line, some of you already alluded to that, are really difficult to get durably complete. Yeah.
No.
And that's why we then sometimes go there.
Yeah, Isabel, how do you? Because I think not only are anterior lines difficult to block, but they're only very difficult to assess endocardially if you don't do epicardial mapping. Many times I've been in doubt: do I really have a complete block of the anterior line of a Bachmann's bundle? So how do you at your center assess an anterior line?
We look at the timing of the HD grid. So we have always 2 catheters in the left atrium that enables us to do differential pacing. But I look also in sinus rhythm at the activation of the appendage. And we place the HD grid in the appendage, and we see, while you do that line, you can see how it jumps to a later activation if the line gets complete. And if we don't get this late or later activation of the appendage, then I'm very skeptical that the line is blocked, and we really try then to ablate as long as this is achieved. And that's sometimes horrible. Yeah, of course, because as you said before, sometimes I think you can block it only, with brute force or epicardially. And that's where I'm curious how focal PFA will fare. Because we did some cases with these anterior lines that came back with the Galaxy system. And that was quite interesting to see that most of these lines then stayed blocked. So the PFA energy seems to offer some advantage here, at least if it's hooked to that specific generator. Okay, so this looks like a very nice typical flutter.
Yeah. The evidence seems to suggest that PFA performs better through SCAR, doesn't it, than RF? RF finds it more difficult to get epicardial through SCAR.
Yeah. Yeah, as I said, our results were a little bit surprising to me, but we almost on purpose tried to use PFA in these cases because I said, you know what, we tried twice with RF. It didn't block durably, so let's try something different. I mean, we can't try the same thing over and over again, and that was very positive for us to see that this seemed to work quite well. Okay, so it looks like a typical flutter, and I'm going to ablate here, and I think that I will use the
Isabel?
long sheath. Yeah, I go with the ablation catheter there, just one entrainment and a lateral isthmus to confirm that. Can we change to the flutter? Thank you. Okay. And that gives us the opportunity to show this new automark index also that Abbott developed with a TactiFlex catheter, which is also one of the topics here in this live case. Okay, so maybe we can just first entrain a little bit in the lateral isthmus. Okay. Okay, let's go here maybe. Yeah. Oh, there's the atrium is almost hidden, but it's early. Yeah, it's early, and that's the ventricle. I just wait. I look for a better place. Maybe here. Yeah. And it's very early, very perfect. Okay. So let's then have maybe 40 watts, please. And the automark index basically takes into account the contact force, the current, the duration, and all of this, I think, is taken full 10 or something like that. So I tried to remember that formula, but approximately it's that. Okay. And you will see the automark appear. Yeah, exactly. They're up there. And it's here 48. So we learned from the analysis of our cases that it's around 50 is a good lesion. And that's what we are going to do, aiming at 50 per lesion. A little bit maybe
arrows
above.
On the ablation catheter, Isabel, showing the direction of force. Is that?
Oh, yeah, that's true. I didn't notice that.
I have,
Why don't I have that?
But it's interference with the X-ray.
We have metal diffusion. Yeah, I'm sorry.
Okay.
We're inhibiting the NAVEX system with our now. That's better.
And an audience member has asked, what about halos? Is anyone still using halo catheters for this type of work?
Oh. Well, we don't. I don't know. Anybody else of you?
I mean, for us, we moved to 3D mapping for these kinds of cases, so we wouldn't have a use for it.
technique.
I do think the activation is concerning there down. Yeah, it seems to be coming towards the ablation lesion set, doesn't it? Those arrows. Rather than going away.
Yeah, and then going through but I think it's because I did not really map nicely the bottom of the isthmus. You see it's getting later and later, and then I think there's an early mid slate on the...
I'm just a bit concerned with the entrainment that I can't fully understand it, but maybe you want to carry on ablating, and then we can look at that. But it's like after the last paced beat, there's quite an early A, isn't there? But then there's a much longer A interval. So I'm not sure what's going on there, really.
That's true, yeah.
And
True,
also, it looked like you accelerated the cardio, but I couldn't really see it. The green doesn't come up very good on my screen, actually, here. But it looks funny to me. And as John pointed out,
it looks funny, it's true.
There's this looks like there's a coalition of the wavefront, the lateral isthmus, but which could be that you, as you said, because of the mapping. But I would, I mean, it could be a CTA flutter, but I would be worried that this is actually a septal complex septal atrial tachycardia.
Yeah, I think that it's not a single re-entry, as I said, because I'm totally sure that our initial entrainment was correct.
Yeah,
and
me too.
Also this entrainment from this anterior scar was positive. Now it's getting a little bit longer. It's just a tiny change in the cycle length of about 10 milliseconds. But for me, the CS sequence looks also a little bit steeper. So I have the feeling it's not that single easy understandable thing that I'd like to show you.
Isabel, do you know how much of the cycle length we have mapped in the two atria? Yeah, but between the right atrium and the left atrium, have we actually mapped?
I have to ask. Maybe we can find it out. Alex?
We have not for the cycle length.
We don't have the full, really?
Yes.
You know what? I should have started on that anterior wall, I tell you.
Can I ask the Abbott team or experts, the arrows that are shown on that map, are they only appearing in points where you've got data, or do they interpolate? Because you can see arrows going towards the line on the medial of the isthmus, but if that was interpolation and you haven't acquired points, then that could be just an artifact rather than a true phenomenon.
Yeah, I think it's, Alex, you have to correct me, but I think it's not interpolating, no?
That's correct.
Yeah, so that's actually true. And you know what is getting on my nerves is that, of course, it's not stopping, that's one thing, but normally we have now some instances where you had a longer RR. And you can see that with my atrial signal in the isthmus, I'm not on the plateau phase of these P waves. So normally in typical flutter, you have these sawtooth pattern. And normally when you're in the isthmus, your atrial signal is just in the middle of that slow deflection downwards. And I'm not. So I think that I will be able to complete that isthmus without any effect on that whole flutter, unfortunately.
But still a reasonable thing.
And we have now
a low risk thing.
Yeah. It doesn't harm. Yeah. So, okay. I think I'm going down there once to the vena cava, and then I go back to my anterior wall because I hate this.
So very interesting that we've got on the maps now activation originating in the septum on both right and left sides.
Exactly. Yeah.
Which makes this really complicated. The anatomy here is so difficult.
Yeah.
I think, Isabel, I think it would be, if you're not too tired of entrainment, interesting to entrain at the high right septum, because I think this could be a septal tachycardia, and that would
a septal re-entry.
Yeah, and that's the worst you can have, really, I think, because then you will not get it rid of the lines that we mentioned.
We have a very bad word for septal re-entries here.
Yeah, so maybe
Very
somewhere
bad.
there where you are now, or maybe just somewhere there. And
okay, maybe here. So let's try entrainment here.
Yeah.
It's a little bit longer now.
Okay.
Maybe you're just okay. It's capturing.
Yep.
Huh.
Let's have a look at.
Okay, can we measure? I mean, at least it's good. Yeah, but it's 380.
Yes, it's not.
Can I see where I left the left atrium? Yeah. Just a second. That's very nice with the Navex system or any 3D system, of course, that you can come back non-fluoroscopically to your left atrium. You don't have to do radiation.
And it was pretty smart of you redoing that map on the anterior wall, Isabel, because you can see that there's I
think that it's
circuit
there
on that little bit there.
Yeah, exactly. Can I do a very bad thing? I'd like just to go through that wall. Okay, can we have 50 watts? A lot of seconds. And a true AP look on that left, please. And can I have that? Yeah. So we start down here. And we just try, because I'm almost sure that it has to do something with this scar. Okay, now you can see that this automark index is going up relatively quickly because I have a good contact. And 50 watts, also a lot of current probably coming back to the system. Cycle length is prolonging a little bit. Not very impressively, but still.
Yep.
You know, sometimes you just throw away this whole stuff and believe into your intuitions. Okay. Yeah. It had to be that. Okay. Anyway, we are going to do our homework and all the lines that we have to do. As I said, can I see the voltage map once? Yeah. You see that, and even with the HD grid, we were not able to delineate the whole reentry there, but it's a localized reentry there. And as I said, we had capture in this very low voltage area, and that's always something that is very, very indicative that this is the right place to go. Oh, okay.
So, Isabel, it's very odd, isn't it? Why was the activation sequence in the CS? There must be very slow conduction coming around that lateral wall to produce that. To distal
I think it's sort of it's a re-entry on the anterior wall that has bystander going around the mitral valve, sometimes at least, and then also having a bystander loop in the isthmus. So it has, the activation, as you say, has to come to the CS ostium. It's not only a localized re-entry there.
But it's unidirectional block in this area. You have unidirectional block and it has to go around.
Yeah.
Well, there may be a long line of block, so it has to go all the way up and around to get to the distal CS. And by the time it's done that, the CS proximal is already activated.
Yeah. As I said, that's very funny.
While you're doing your ablation, let's have a quick look at the poll, if we may. Can we bring up the poll that you asked questions on? So most people would do exactly what you've done, is LAT and entrainment, and only about 15% would do it the correct way, which is LAT only, which is what John and I would do. Only joking.
Oh, there is a tremendously interesting paper about rhythmia maps of Flutter, which I happened to run into when I was preparing a talk for the PD Rhythm Congress. And they said that about 15 to 20% of the rhythmia maps, when they were controlled with entrainment, were total rubbish. So that that told me, okay, okay. Can we pace with the CS 910, please? We have with this low heart rate now, we have a drop in the in blood pressure. Und kannst du einen Bolus nochmal geben?
Haben wir gerade 0,2?
Ja. Ja, kannst doch 0,4 geben. Geh mal 0,4. 0,4 Bolus? Nur? Ja. Okay. So we are pacing right now. And I'm finishing that line, and then I will exchange the ablation catheter with the HD grid and have the HD grid in the appendage, pace from there, and introduce the ablation catheter close to the HD grid again in the left atrium, so that we have two catheters in the left, and that we can control this line. And I think I'm going to draw it to the right superior, because the low voltage area is extending a little bit in that direction.
So it's interesting using two catheters, which is exactly what I do. There's a vogue for just using one and exchanging, but I really like having two catheters in there simultaneously so I can check lines and see changes in transition.
Yeah.
John, you were going to say something about...
Yeah, no, I'm just really interested to know about this ablation index, because I was a little bit disappointed when the Tactiflex came out and the LSI was gone, and we were told to just use energy or time, etc. And we don't have access to this this software, I guess, in my institution. And I just wondered what Isabel.
We have it only for 1 week. It's really the newest of the newest. So we are sort of collecting our first experiences while you were watching. So it's I
and
think case number 7 or 8.
Cases? Do you use different numbers for the front and the back?
Yes, because in fact, whatever did, they analyzed our rings around the right and left veins. For PVI, we use really a high power short duration, so 65 watts and up to 15 seconds. And we have here this limit of 7 to 8 seconds on the posterior wall, not longer, to have shallow lesions. And it matched very well with our experience. But what they found out is that, in fact, we had a lower first pass isolation on the left side, but also had lower automark index values on the left side, especially on the ridge. And so now, to be honest, we are looking all the time at the automark index, especially when we're doing the ridge. So we really try to go above 50 per lesion. And this was mainly due to insufficient stable contact. So that's why the automarks index numbers didn't go up that nicely. Whereas on the right side, I think we had a relatively high rate of first pass isolation with these slightly higher values.
Well, I think
and on the posterior wall, I think that 40 is way enough, so you don't have to stay there a long time.
So I think we're beginning to come to the end of our time now. I think it's been an amazing session because we've seen some proper old-fashioned electrophysiology. You've shown us all the potential pitfalls that can occur with both activation mapping and entrainment. So I think it's been a really interesting case. I'd really like to thank Finn and John, who've really done some great contributions. But Isabel, thanks so much to you and your team for giving us another really amazing case. And I'm just sorry that we couldn't stay to see the line of block occur. But thanks very much, and we'll be moving on to our next session very shortly.